Um, Dr. Joseph, um, thank you again for being here almost every single week with your information that you share with us. I am so looking forward to hearing what you might want to talk to us today about. So, Dr. Joseph, you're up.
Well, thank you very much, Mr. Mayor. And again, thank you for the invitation. These are always enjoyable, and I always learn from all of the panelists. I will just, before I get started, let me embellish just a little bit about what Ann Lucena said. I totally agree with the safety of the hospital and the doctor's offices. Let me add to that dental care. The dentists have extremely strict guidelines in order to provide a safe environment. Remember that what a dentist does is creating an environment that puts this virus into the air. And therefore, they are the ones at greatest risk, not the patients. And because of that, the American Dental Association and local dental societies have given them guidelines that are almost, if not more, strict than what we have in the intensive care unit of a hospital. So I would encourage those who need dental work not to put it off because of the current pandemic. And I'm going to share my screen now. And someone will tell me if this is not showing up, but it looks like this is it. And again, the title is not getting over COVID, but learning to live with it. It is going to be with us. And so I'm going to have some remarks today that we have regarding PCR testing, those that have persistent symptoms, some aspects of medical modeling and contagiousness that we have learned, and I'll discuss the case fatality rate and the impact that may have with us. So this is a cartoon on the left. It's actually a real person with a cartoon imposed on it. This is the way the standard original nasopharyngeal test was collected. So the swab, this has been, I think Supervisor Anderson called this a brain biopsy, and sometimes it feels like that. There are alternatives to this now, but this is the classic test of how it was first described. There are other tests where the swab does not go back as far, and there are even throat swab tests that can be done. But the typical test is the tip of the swab is twirled and picks up both mucus and cells that may have virus in the back of the nasopharynx. Now, what I want to focus on now is what's on the right. The term PCR is common knowledge to almost everybody now. The CR means chain reaction. This is a chain reaction test, and the cartoon on the right shows a picture of the coronavirus, and the coronavirus typically has only RNA or nucleic acid in there. That sort of yellow cream colored chain that looks like a string of pearls or a string of beads is the only thing that's in there. This virus can't live by itself. It has to get inside a cell. But the PCR test does not look for the virus. It only looks for small segments of the nucleic acid. And I've put 3 circles there because there's 3 options that we use in the laboratory. And typically a test will identify 2 of the 3. So it's not looking for a whole virus. It's just looking for a fragment. If an individual has symptoms and these small fragments of the virus are detected by a laboratory, that's enough to make the diagnosis of an infection. Now, the reason I brought this up is because these fragments of the virus can hang around in a person's throat for a long, long time. But remember, we're not looking for the virus, we're just looking for fragments of the nucleic acid. And this is what happens if we look first at the cartoon on the left. The red bars are how long that pieces of virus can be recovered from the throat. So at 3 weeks, still 1 out of 3 patients has fragments of virus in their throat, but they're not infectious. The yellow arrow at the bottom of that graph is about 10 days after the onset of symptoms. And for the typical person who is out of the hospital, a community infection, that's when they become non-infectious. And that's why the guidelines over to the right for the average person that was mentioned by Supervisor Anderson, they can go back to work 10 days after the onset of symptoms, as long as the symptoms have improved, and 24 hours without a fever. And that is the overwhelming majority of the patients. So doing testing on those individuals will still have a positive test, but it is not recovering contagious virus. It's not recovering infectious virus. It's recovering fragments of nucleic acid that are still present in dead and dying cells. So the PCR test is a great way to make a diagnosis, not a good way to determine the lack of infectivity after a diagnosis. So it's no longer used. And I say that because in the beginning, it was required to have 2 negative tests before we could say a person could go back to work. And that's no longer used. And you can see why by the red bars, how many people will be positive, even some out to 5 weeks. And I've had patients who have been positive for 2 and 3 months, but definitely not infectious. The next topic is symptoms. On the left side, in the blue bars, are the number or the percentage of patients who have symptoms when they have an acute infection. And you can see that being tired or fatigue, breathlessness or cough are the highest on the list. But looking at the right, this is a large group of patients, 1,300 patients that were sampled 2 months after complete resolution of the virus, 2 months after they were not infectious, 2 months after the infection is gone. And you can see that almost 60% are still having symptoms of being tired, breathlessness, joint pain. So we're now learning that this virus not only has an acute problem, but a long-lasting problem, and that would be called morbidity. So an individual's ability to recover can be related to age, but this can hang around for a long time and cause individuals not to be able to return to activities of daily living, not be able to carry on their job, particularly if their job requires a lot of physical activity. So this is part of new information that is helping us manage patients not only for the acute diagnosis, but also to reassure them after it's over that they will get better. But this takes a while. This is not something that goes away overnight. Now, modeling. There's fashion modeling that I know nothing about, but there's medical modeling or statistical modeling that we hear all the time on the news. And let's look at this definition, because this has been the subject of far too much accusations, particularly on the national news during an election year. Statistical modeling means that we're using our current information to measure the probability of something happening. And I'll give you an example on this. I hear this on the news all the time, that a particular doctor or a particular newscaster or a particular medical institution lied to us or gave us wrong information. That is an allegation that is not correct. What they did was statistical modeling, using the current information to measure the likelihood of something happening. And inherent in that comment is that there's no change. And this virus has been the fastest changing epidemic that any of us have ever seen. So although someone is saying this is what we have to prepare for, they're also saying that this is what we have to prepare for unless we can make changes to improve the situation. So I'm a firm believer that no one who cares about patients and who cares about science is lying. All they are is saying what was modeled at the time, and that represents a need to change. So the interpretation is different. Modeling tells us that we have to do something rather than telling us what will happen. So let's take a look at some statistical modeling that exists. Contagiousness. Now, the term for contagiousness is R naught. It's a capital R with a subscript 0, but it's pronounced R naught. And the definition is how many new persons will get infected from one case. So if we have a person at a fraternity party who is infected, the number of people that will get infected at that fraternity party is a lot. If we have one person who is wearing a mask and is in public, the number of persons that will get infected from that one case is substantially lower. And if you put all that together, that is the number of new cases from the number of cases that we know of in March, R naught was 2.5, meaning one person in March would cause an infection or spread an infection to 2 or 3 other persons. That's what R naught is. And from an R naught of 2.5, we needed 60% of the people in the country to be immune to create this concept of herd immunity. Herd immunity means that enough people are infected that you don't need to worry about it. Where we are today with chickenpox, where we are today with measles, mumps, and rubella, that we take precautions, but we do have herd immunity. Herd immunity is based on the number of new cases. And so a calculation of R naught changed dramatically between March and July. And currently, with this big uptick, with the steep part of the curve, one infected person will infect 5 to 6 other persons. It's a dramatic change. And that's why the curve changed. Now, what the relation to this is not because the virus changed. This virus did not become more infectious, more dangerous, more contagious. What happened is that more people got it and fewer precautions were taken. So we are currently at our R naught of 5.7. And that means that we need to have about 80% of the people in this country to develop herd immunity. Now, just as an aside, we're currently sitting probably around 2 to 4%. So we are nowhere near herd immunity. And we're not going to get there until we have an effective vaccine. So that's just an aside. Herd immunity doesn't occur by people getting infected. Herd immunity occurs only by vaccine. And that's where we are with all of the childhood diseases. So this R naught means that today, one infected person can infect 5 to 6 others. This is modeling unless we make a change. Now, if we make a change, we can get that R naught back down. So if I go on a national news today and I say one person can infect 5 to 6 other people, and 3 months from now that's not true, it's not because I was lying. It's because from modeling, that was true in that case, and we need, or at that time, and we need to make a change. So this is what we have done in the past. We want to reduce contagiousness. And in scientific terms or epidemiologic terms, we want to lower the R naught. Now, what happened with Ebola in West Africa is a good example. I was involved with the CDC at the time, and it was very clear we could not keep Ebola out of the United States. That was tried for a while. It was ineffective. So we sent a team to West Africa. And the way we reduced the contagiousness is when there was a diagnosis of Ebola in a person, we traced it back to where they lived and we isolated the house, and Ebola went away. Now we can apply those same principles to some degree to our current pandemic with COVID-19. That is, if we identify a case, and a case is a positive test. When you hear number of cases, that is not because people have symptoms. That is not a case in the United States. A case requires a positive test. Then the contact tracing that was described by Supervisor Anderson to find out where they got it or who they may have exposed, and isolate not only the infected person, but those to whom they may have had a contact. So if I'm infected today and we find out that I had close contact with 5 other people, we put all of those 5 persons in isolation or quarantine. And that's how you lower the contagiousness. That's how you lower the R naught. And the other thing is emphasizing the importance of changes in behavior. We are all experiencing COVID fatigue. All of us want to have this gone. And for that reason, we are letting our guard down. And it's people like our public health officer, our community service persons that are saying, no, don't. We can't do it. This is a brush fire. And if you stop controlling the brush fire, it will turn into a wildfire. The only changes that we have right now that need to be emphasized are the big three: masks, distancing, and hygiene. That's what we need to emphasize. If we could get everybody to follow that, the number of new cases would fall like it went over a cliff. And yet we all understand why we don't do it. We're tired, but the importance of emphasizing masks, distancing, and personal hygiene. Keep your hands out of your face. If you touch something, use a hand sanitizer or wash your hands. These will work. I understand why it's hard, but these will work. So the next topic is the case fatality rate, something that is quoted often, sometimes misquoted, and frequently misunderstood. The bar graph on the left shows the case fatality rate by age group. So if we look at the age group of 45 to 54, it's 0.5%, meaning if 200 people in that age group get infected, one person will die. That's how this is calculated. And what we all know is the case fatality rate is related to the age. What's not on here, by the way, are new numbers of infants. That is less than 1 year. They have a substantial complication and fatality rate. This lumps together, for purposes of this slide, everybody under the age of 20. And of course, the older one gets, the greater the fatality rate. So off to the right is how it's calculated. That is the number of persons who die over the number of cases. So if we look at the 45 to 54, and we say there's one death in 200 patients or 200 cases in that age group, the case fatality rate is 0.5%. That's 1 in 200. This is often quoted. But this is the issue that we all must understand. The number of cases is totally dependent on testing. And this can be the good news. It is estimated that there are 10 to 20 times as many persons with COVID as have been tested. And this is because of the difficulties we've had with testing, or the reluctance to be tested. Or even today, I've had patients who call me and they have shortness of breath and they have a cough and they think they have a fever. And they say, why don't I just stay home? I don't want to go get tested. Why do I have to get in my car and go out? I feel like crap. And they make a good argument, but this does skew the facts to the point that we may be better off than the graph on the left. So there likely are a lot of people who have had this disease or even have it, who are not identified as a case because they're not testing. And I want to give that out as good news. That doesn't mean that we still have a number of people dying. You cannot change the absolute fact that we have had almost 800,000 deaths in the world. We've had, well, I think we're over 100 in Contra Costa County of people who have died. So we don't want to discourage that, but I do want you to understand that this is how the case fatality rate is determined. And now some interesting facts. I'm not swayed by the comment that forcing me to wear a mask is infringing on my rights. I don't agree with that. It's like saying for me to have to wear a shirt when I go into a store is infringing on my rights, or having to wear pants in public is infringing on my rights. Wearing a mask is to help others. And these are pictures from 102 years ago. Now, I know that the one in the upper left and the streetcar and on the upper right is a Georgia Tech football game family at the bottom. I know those are all in the United States. I'm not sure about the one with the police officers, where that is from. But this was a pandemic similar to what we have right now. And as you can see, masks were required. Masks work. Masks stop the spread of the virus. They're not so good at protecting you, but they protect those who you are around. And I've said this over and over again. Masks help protect me if you wear it. If I'm wearing a mask, I am protecting you. Masks are important in this pandemic because at least of the third of the people who have this infection don't know it, or they have minor symptoms and they don't think they're infected. That's why we want everyone to wear a mask in public. And this is a common cartoon or a common photograph that is used. Show them you care, wear a mask. When you walk down the street, when you go visit people, show them that you care because you don't know if you are excreting the virus. Now we have about a minute or two left. So let me add something on here that I think is educational. I want to talk about anecdote and how anecdotes can create problems unless you understand what an anecdote is. This is a report that came through the CDC of the spread of a virus in a restaurant in indoor dining. And with research tools, we can tell if two people have the same virus or if two people got the virus at different places. So that is a research technique that is used in circumstances of a closed epidemic. Sometimes we use it in the hospital, sometimes we use it in other circumstances. But these were 10 persons all infected with the same virus on a third floor restaurant. And the third floor restaurant had no windows, but it did have air conditioning. And the air conditioning was limited to that floor or that restaurant. And it was shown that this caused 10 people to get infected from one index case. No one's wearing a mask, of course, because they're eating. The tables at that time were 3 feet apart. This shows that it can happen. Now, I didn't put this up to discourage indoor dining or when we do get back to indoor dining. I put this up to discuss anecdote. An anecdote is something that is recognized as having happened in medicine. A medical anecdote happens once. It is an impetus to study. This does not mean that this is the norm. So when you hear something on television or when you read something in the news, ask yourself, is this an anecdote or is this something that is confirmed to be a reality or a probability? This is the only, of all of the indoor dining that is occurring around the world, this is the only one that I know of where it has been spread by air conditioning. Typically, we say that air conditioning is beneficial. So I put this up as an anecdote, as something that is maybe a one-off. It may never occur again, but it is an impetus for study. So pay attention when you hear things. Is this something that is likely or reliable or probable, or is this something that we don't need to worry about until we get more information? And so with that, I will stop my remarks for today. I thank you again, Mr. Mayor. It's always a pleasure, and we'll just see what happens next.
Thank you, Dr. Joseph.
Another question, I've received one from somebody who appears to work in the healthcare industry, and that they often hear people infected despite precautions. You know, they're only going to grocery stores or pharmacy and they're wearing a mask. And the question is, what is the latest thinking regarding the transmission from aerosol virus particles? So Dr. Joseph, I don't know if this leads into the anecdote discussion that you mentioned, that there might be unique situations where people get it despite wearing a mask, but if you can expand on that a little bit.
Right. So the masks that we are encouraging are exhalation filters. They work for those people who are shedding virus to help protect others around them. They are not 100%. And that's one of the things that maybe I've never emphasized, that although they are beneficial, it is not 100% effective. It does not capture 100% of the virus that is being spewed from a person who is infected. If an individual is known to be infected, there is no reason for them to leave the house other than an emergency. Simply stated, you don't go to the store, you don't put on a mask, you don't go to the supermarket in knowingly being infected. That mask is not 100% protective of the other people in the store. You must stay home.
I had a follow-up question for Dr. Joseph. If somebody might be infected but asymptomatic, are they shedding so few viruses that a mask should protect those that are around them?
No. The amount of virus that is shed can be the same for asymptomatic as moderately symptomatic. Those who are severely ill in the hospital are in a different category.
Thank you.
Right. Another question, and Dr. Joseph, I believe we've you've addressed this one in particular, and it may have been in episode 3, 4, or now that we're up to 15. It is a popular question, and it's worth readdressing briefly. What are the risks of contracting COVID from lap swimming in a community pool?
Very, very small. Lap swimming, lanes and lap swimming are now designed to be far enough apart that it's extremely unlikely that a person will cough or spit on another person. You almost have to imagine a situation where that could occur, but it requires face-to-face. But typically, individuals who are capable of that type of exercise are not coughing, not sneezing, and not symptomatic. So if the amount of virus, as Mr. Mayer mentioned earlier, although the same amount of virus is exhaled by talking for those who have symptoms or those who don't, coughing and sneezing increases that many-fold. Lap swimming, in the absence of unusual circumstances, is safe.
All right, and then also this one for Dr. Joseph, can you provide an update on a vaccine development? And as a medical professional, how confident are you in the development process currently underway in the US?
Good question.
My confidence is high. I've been involved with vaccine development for many decades. And what we are doing now is not only having the usual process by 1 or 2 companies, but we're having novel processes by at least 50 companies trying to develop a vaccine quickly. And the reason my confidence is high is when you get that many brilliant minds with one goal toward the end, and this is far more, by the way, than we've ever tried for AIDS, or RSV, other things that are very difficult to make a vaccine for. So my confidence is high because of the bright minds, the number of people, the resources behind it. The timeline is going to change for our benefit. And I've not mentioned this before, so it goes something like this. Typically, when you develop a vaccine, you give a vaccine to 30,000 people and you give a placebo to 30,000 other people, and you follow them over time and see if there is a difference in the infectious process. And so it takes time. And that's why we are always saying that, vaccine development takes a year or 2. It just takes time for natural history to show a difference in those 2 groups. We are approaching a situation where it may be permissible for volunteers to expose themselves to the virus. Now, you can do this with animals, and animals, it's being done with camels, llamas, monkeys, all of whom can be infected by this virus. But if we create a legal situation and have volunteers who are willing to expose themselves to the virus, the timeline will be dramatically shortened, and we could have something much sooner than expected.
Great.
Any predictions?
No.
Okay.
You want predictions, you go to the nightly news or the YouTube, but no.
Well, I'll rephrase it. Do you think a year from now there'll be a vaccination?
I really don't know.
Don't know.
I think I've never, as I said, in my career of several decades in infectious diseases and immunology, I have never seen this much effort toward one goal, and that is to protect a healthy person from getting infected.
There have been some some tests that have gone through at least 1 or 2 layers of protocol and appear to be promising. So does that mean there may have been a vaccination that's already been created that will work, but just needs time before it becomes viable? Or do you think that no one's discovered the keys yet?
We may have discovered the keys. Trials have already started. Phase 3 trials is where you're giving it to healthy subjects, and we're in the tens of thousands of persons who have received investigational vaccines. And if that works, the answer to your question is, yeah, we found the key to the lock.